So I'm gonna present the talk that I gave at Heart Rhythm just a few days ago. So let's see here, we got Josie, Grace, David, Tarek, Sergey. So why don't we wait another minute or two and then we'll get going. We'll just give 1 minute and we'll get going. All right. Okay. So, you know what? I just want to make sure I'm sharing the correct screen. It's actually this screen which I want to share. All right. Can you guys see the big display screen?
Yes.
Yes. Okay. Thank you. All right. So this is a talk that I was invited to give at the Heart Rhythm Society meeting last week. I figured maybe you'd be interested. So the title that I was given was How Many PVCs is Too Many in the Adult Congenital Heart? And this was a session on issues related to adult congenital heart disease, but it was really an electrophysiology, but it was really sort of a potpourri of various topics that were some electrophysiology related, such as this topic, and others that a little bit less so. There was a talk on genetic counseling in adult congenital patients, and talk on a couple of other arrhythmia topics. Okay, so so what's known about the topic of how many PVCs is okay in an adult congenital heart patient? And it turns out that there's actually surprisingly little on this, which is probably why the topic was assigned to me, because generally speaking, they don't want me to talk about things which there's a lot known, or perhaps they want me to collate what is known so that maybe in the future people understand the literature better so that they can perhaps formulate new ways of thinking about it. So when there isn't all that much data, we usually will extrapolate, make assumptions based on what we do know. And that's, of course, a prime way in which we do everything in medicine. So the first thing I wanted to look at was what is known about PVCs in healthy adults. So PVCs, it turns out, are actually common in all human beings. About 2 to 4% of adults will even have them on a 12-lead ECG. Just in the 15 or 20 seconds it takes to do an ECG, 2 to 4% of all adults will have a PVC in clinic. And if you go to patients who are over 65, and these again are healthy adults who don't have congenital heart disease, 5 to 10% of patients just on a 12-lead ECG will have a PVC, which is really pretty remarkable. And as you know, there are literally thousands of studies done in adults, and this is one of the largest ones, the so-called Framingham heart study, which is a longitudinal study of a group of men and women over literally 30-year period, looking at various factors associated with cardiovascular health. And this is a complicated slide, but the most important thing to look at is that if you do just a 1-hour Holter on patients, on adults, 12% of men will have complex or frequent ectopy in just a single hour of Holter monitoring in an adult patient. And just in case the women in this small audience think that this is limited to men, the data were the same for women. So about 12% of patients, adults, will have actually complex or frequent arrhythmia on a Holter, PVCs. So PVCs are common in adults, particularly in older adults. And 40 to 75% of adults will have PVCs on a 24 to 48-hour Holter monitor. So PVCs are not uncommon. So the whole thing in this topic is really separating the wheat from the chaff, as it were, and figuring out who are the patients who are at risk. By the way, since we're here, does anybody know who this gentleman is up here on the top? This isn't, nobody knows, huh? Guys can hear me?
Yes.
Yeah, there's a guy named Jack LaLanne who was a very famous fitness expert in the 1960s, 70s, and 80s. And he was, this is a picture of him. Looks like he's in his 70s in this picture. And he died after heart surgery in his 90s. And he used to say that he couldn't die because it would hurt his image. The interesting thing about him is, he was famous for not ever having any fat or processed sugar. He was very proud to tell people that since like 1947, he had never had a piece of fat or processed sugar pass his lips, and that was the secret to his longevity, except he failed to tell everyone that his overweight smoking brother lived to his late 90s. So genetics also plays a role. Okay. So why do we care about the PVCs? There are really two major reasons. The first is the potential for tachycardia-induced cardiomyopathy, and the second is because of the risk for sudden arrest or sudden death. So let's start with tachycardia-induced cardiomyopathy. So the question is, how much is too much? So the predictors of myopathy in the healthy adult, this number here of 24% is highly associated with myopathy. And this comes from what is considered a very important paper in the adult literature from about 12 years ago. On the y-axis is the PVC burden, and on the x-axis is ejection fraction. You see that as the PVC burden rises, the numbers of patients with low ejection fraction rises, and there's an inflection point at about this level of 24%, at which point we see function pretty reproducibly, and most adults will go down. Now, this does not mean that at lower levels of ectopy, you could not have ventricular dysfunction as well. But I think in the adult world, most would say that in an otherwise healthy person, an ectopy burden of 24% and greater is probably an indication for treatment based on these data. And, just out of interest, in children, what are the data? And this is a study from the Netherlands looking at a fairly large cohort in their practice. And bottom line is that what they found that in children is that PVCs are also associated with dysfunction, but you need more PVCs as a general rule. So, in the adult world, they have some very strict cutoffs, but in pediatrics, we all know of patients who have more than 20% PVCs who do not have dysfunction. And so it seems that in a pediatric patient, you generally need more PVCs on average. It's not to say there aren't patients with a lot of PVCs below that number of 24% who get dysfunction, but generally speaking, children seem to tolerate higher density of PVCs without problem, more non-sustained VT or sustained VT or couplets. These are all factors that in this large scale study were associated with dysfunction in kids. And as I said a moment ago, some patients with 10% or more PVC burden will also develop cardiomyopathy. So, and so people have tried to look and try to figure out why is it that some patients are fine up to this magic number of 24%, but other patients do not seem to tolerate even smaller numbers. And some studies have shown that a QRS duration on the PVC that's greater than 150 milliseconds, or a very wide QRS PVC, may be associated with cardiomyopathy. Some have suggested that non-outflow tract origin PVCs, perhaps consistent with more dysynchrony, are associated with more tachycardia-induced cardiomyopathy. And so those are the general thoughts about it in adults who have structurally normal hearts. But really, when it comes to data on PVCs and the development of myopathy in ACHD patients, there's really not very much, if anything, on this topic, except to say that as a general rule, we would assume that patients who have pre-existing heart disease probably would be susceptible to the ill effects of something like a PVC more than a patient who does not have congenital heart disease. Now we move on to the risk of sudden death, which is the other concern when you're seeing a patient with PVCs. Because always with PVCs, I joke, you're asking yourself the question of whether there's smoke, where there's smoke, there's fire, or where there's smoke, meaning it's either risky or not risky. And really, this is a whole question of this talk, is trying to figure out who do we have to really be worried about. So it turns out that it depends on the patient in terms of what the risk is. So in the otherwise healthy adult world, or in the non-congenital adult world, patients who have coronary artery disease would be considered high risk. Patients who have any kind of cardiomyopathy, like hypertrophic cardiomyopathy or arrhythmogenic right ventricular cardiomyopathy or dysplasia, these are patients where I think we would all agree they are at risk just because of their diagnosis in general. And there are many studies showing that PVCs of a certain type and length are worrisome in those types of patients. And then, of course, patients who have arrhythmia conditions associated with sudden death, like CPVT or long QT syndrome, would also be associated with sudden death risk, and PVCs could potentially be an ominous sign. So this is a statement or a state-of-the-art review by the American College of Cardiology EP Council for adults who do not have congenital heart disease. And these were basically a summary of the factors that they felt would potentially augur a non-benign characterization or character of PVCs. So these are the things that would be more worrisome to an adult cardiologist, or should be more worrisome. And these include underlying structural, ischemic, or electrical disease, very frequent PVCs, more than 2,000 per 24 hours, but we talked about a percentage burden. Here they say even more than 8% PVC burden could lead potentially to LV dysfunction. And so recommendation is for follow-up serially, but I think we would all agree that that's a good idea. Complex PVCs like couplets, triplets, or non-sustained VT, again, something we would normally do. Different morphologies, monomorphic PVCs or unifocal PVCs are generally less risky, we believe. More PVCs with exercise, that's generally in adults and children thought to be a serious concern. There are a lot of studies in adults showing that more PVCs with exercise is a dangerous finding. Surprisingly little in children, but we still, I think it would be fair to say that most pediatric cardiologists believe that if you see more PVCs with exercise, it's worrisome. Of course, we know that in the condition of CPVT, that's one of the sine qua non of the disorder. But I think even in patients who don't have that, if we see more PVCs with exercise, most cardiologists would be worried about that. Again, non-outflow tract PVCs would be potentially more worrisome for non-benign characteristic of a PVC. Potentially, we talked about the risk of dysfunction from those. Short coupling interval of PVCs, and then wider PVCs. So what do we know, though, about PVCs in adult congenital patients? So this is a study from the group at Stanford, and this study really was intended to look at or ask the question of whether or not wearing extended monitors like the Zeo patch was better in identifying arrhythmia in patients than those who do not have that long monitoring. You have to understand that the technology to do a Zeo patch, or the competitive product, is something called a Barty patch. These devices didn't exist even 4 or 5 years ago. And so traditionally, and if you look in most of the literature, the data are based on 24 or 48-hour monitors, not on these long extended monitors, which, as you know, in the case of the Zeo, can go as long as 14 days. So this study was really intended to see, do we find anything important after the first 2 days? Now, the reason, though, that I'm showing this study today is not because of that fact. It's really more that it's one of the very few studies that actually looks at prevalence of PVCs in ACHD patients. And essentially what they found was that approximately half of all of the 314 patients in this study had what they characterized as significant arrhythmia. The most common arrhythmia was SVT, some form of SVT, seen in 35%, of these patients. And this is consistent with lots of data on things like tetralogy. You know, we always are worried about sudden death in patients with tetralogy, but in actuality, atrial arrhythmia is far more common, although not as life-threatening. But interestingly, and perhaps unexpectedly, 11% of this cohort had non-sustained ventricular tachycardia at some point during their monitoring. So this is a curve looking at freedom from any arrhythmia, SVT, non-sustained VT, and atrial fibrillation. And they're in different colors here. So on the y-axis, we have freedom from arrhythmia. On the x-axis is the number of days of monitoring. So the first thing that you observe is that there is a continuation of these curves downward over time. That was really the main point of this study, that although, you know, if you sort of drew a line at 2 days, you would miss a fair amount of arrhythmia in this patient group. But the reason that I chose to present this in this talk is because it's just to look at the VT and take that out. And we see basically that if you measure out to about 14 days, only about 80% of adult congenital patients have freedom from VT. So that's a fairly substantial burden of ventricular arrhythmia in this patient group. The other interesting thing is that if you break them out by age, you see that age really does matter, meaning, and specifically, being older is bad, as is true in almost all disease. So you see here that if you're older than 45 years of age, by 14 days out, we're basically saying 80% of patients had some kind of arrhythmia reported, which is really a little disturbing. This is any arrhythmia. Another interesting thing that they did was they break it down by some diagnosis characteristics. So again, on the y-axis is freedom from non-sustained VT. On the x-axis is days of monitoring. And we see these are 3 of the highest risk categories amongst the congenital heart lesions that they looked at. And these are things that we should be worried about, or more worried about, specifically patients who have left heart obstruction, like aortic stenosis or subaortic stenosis, patients who have tetralogy or tetralogy-like disorders like double outlet right ventricle, and then single ventricles. So these, in this particular study, these categories came out as higher risk lesions for the potential risk for non-sustained VT. And so to summarize, looking at their multivariable analysis, age or older age was associated with more common arrhythmia identification in long-term monitoring. Presence of single ventricle was left heart obstructive disease, and then a history of arrhythmia, pointing out again the importance of history always when assessing patients. So this study basically showed that diagnosis and age both matter when we're thinking about PVCs in the ACHD patient. So, you know, again, we want to know which diagnoses should we be particularly worried about. And in actuality, in 2014, the PACES, or Pediatric and Adult Congenital EP Society, and HRS made a consensus statement on how to assess and manage arrhythmias in the ACHD patient. Actually, Paul Carey, who was the first author of this work, was the moderator of the session I was speaking at. And they have this very nice table in this document looking at what they think are higher and lower risk for atrial, ventricular, and other arrhythmia issues such as need for pacemaker. But I just highlighted the ventricular arrhythmia because that's the title or the topic of this talk. And they basically identified coarctation, aortic stenosis, Epstein's anomaly, tetralogy, double outlet right ventricle, detransposition, and L-transposition as the higher risk categories, characterized by, in this diagram, is either a medium blue or a dark blue or a navy blue color here. And this is based on expert consensus as well as a review of the literature by this group of doctors. And so if we were going to sort of summarize from the Stanford group, as well as this policy statement by HRS and PACES, I think it would be fair to say that when we're looking at patients with ACHD who have PVCs, there are clearly higher risk diagnoses, and these would include patients with cardiomyopathy, patients who have tetralogy of flow-like diseases like tetralogy or double outlet right ventricle, those who have a systemic right ventricle, like those who have LTGA or DTGA following an atrial switch procedure, like a mustard or Senning. Patients with single ventricles, of course, we're thinking about hypoplastic left heart patients, but any single ventricle. And importantly, those who have LV outflow obstruction. Another important factor is that of symptoms. This is from a paper by Joe Atala when he was a fellow at Boston Children's. He's a prominent electrophysiologist in Canada, in Western Canada. And they came up with a way of scoring tetralogy patients to figure out who's at the highest risk for sudden death and what factors should be used in coming up with a risk categorization. And they actually were able to come up with a scoring system with the so-called importance factor. And it's interesting, they were able to show that it mattered which era you were repaired in the 60s to 70s or the 80s to 2000s. But I thought it was important to mention that the presence of symptoms gave a patient a very high number of points in the total category risk. And so, and that was true whatever era you were repaired in. So the presence of symptoms, particularly fainting with or without palpitations or palpitations, is an important risk factor. And we should take this is a symptom that should be taken seriously, which is hard because, of course, so many of our patients complain of palpitations. But certainly, if you have a patient who has one of these high-risk lesions and is complaining of palpitations, a full evaluation is clearly warranted. So what matters then? Clearly, if you're in the higher risk congenital heart categories, if you have a high percentage of PVCs, if you have symptoms, and if you're older, these would be the higher risk categories of patients in whom PVCs might be more important. So according to this policy statement, if you were symptomatic with PVCs, the class 1 recommendation, which, as you know, means that basically you should be doing this, is an H&P, an annual 12-lead ambulatory ECG monitoring like a Zio or a Holter monitor or a Barty device, event loop recorders, routine interrogation of implanted devices, which, as you know, mostly have telemetry in them. They discuss the possibility of implanting a loop recorder. And then as a class 2A indication is the possibility of doing exercise stress testing. In terms of invasive recommendations for assessment, the class 1 recommendation, they say that EP testing with programmable A and V stimulation in adults with unexplained syncope and high-risk congenital heart disease substrates with primary ventricular arrhythmias. So they're basically saying that if you have a patient who has complex ventricular arrhythmia who's in one of those high categories, it may not be unreasonable to do an EP study. In fact, it may even be preferable. And for class 2A is doing someone who has a life-threatening arrhythmia or resuscitated sudden cardiac death when the proximate cause is unknown. So I think that's pretty standard. So based on all of these, I decided to come up with what I felt were reasonable algorithms based on what we know in the literature, which, as I hopefully realize, is not all that much. So I think if you have a patient who presents with any cardiac arrest symptom, meaning they've literally arrested, whether they have a lot of PVCs or very few PVCs, I think that basically those patients almost 100% of the time would warrant implantation of a defibrillator, plus or minus an EP study and ablation. But I think in somebody who has arrested, it would be unusual for us in the present era not to recommend an ICD. Even if we felt we had ablated something that could have caused the arrest, I think it would be hard for us to feel comfortable that that would be adequate. Now, I then came up with an algorithm for patients who are low risk adult congenital with PVC. So that would mean that they do not have cardiomyopathy, tetralogy type of disease, systemic right or left ventricle, LV outflow obstruction, or Epstein's anomaly. So this is for patients who are not these diagnoses. So if you, and I would treat them very much like a regular adult patient. So we're talking about people, for example, like a repaired ASD. And again, this is just my own personal algorithm based on my literature and experience. So if the burden of PVCs are, you have isolated PVCs and the burden is low, we would typically do an echocardiogram. If the dimensions and the function were normal, then we would just continue to follow this patient with typical outpatient monitoring. If, however, there were abnormal function or dimensions, then we would normally treat this patient's PVCs either with ablation or medical therapy. And if the number of PVCs was very large and they were isolated, we would probably also treat it because of concerns of the development of myopathy. Now, if you take that same low risk patient with PVCs, but you make them symptomatic, well, then I would say that pretty much for a symptomatic patient, if you are, whether you have a relatively low burden or high, we would generally treat these PVCs with either ablation or medical therapy. Now, what about the low risk patient who has many couplets or runs of ET, whether they're asymptomatic or symptomatic? Well, we would do all of this evaluation, but in those patients who have a lot of runs or couplets, we would probably do an EP study in such a patient. We might ablate that patient and we might consider placement of an ICD depending on what the observed arrhythmia were. For example, if we had a sustained monomorphic outflow tract VT that could be easily mapped and ablated in an otherwise low risk patient, we might not think that an ICD is necessary. But then there are patients like the tetralogy patient, which we'll talk about in a moment, in whom we cannot necessarily hang our hat on an ablation because they are at risk for other ventricular arrhythmia. Now we'll move on to the high risk patients. So the first thing to remember is that some of these lesions, there are more data than others. So for example, patients with cardiomyopathy or tetralogy, there's a whole literature on what to do with these patients. But as a general rule, in an asymptomatic high-risk patient with PVCs, if the number of PVCs is in the low range and they're all isolated, and the function was normal, I'd probably just follow them just like I would any other patient. And similarly, if there were abnormal function or dimensions, treat them like a low-risk patient by treating the PVCs and ablation. If, however, the burden was high, we would probably treat the PVCs and we might at the same time do an EP study and consider placement of an ICD in such a patient. And if the patient was having actual VT, whether on ambulatory monitoring or even in the cath lab, I think that probably we would consider placement of an ICD in such a patient. Now, if we had a high-risk patient who has PVCs and the patient is symptomatic but has not arrested, again, it's important to review the literature for each particular congenital heart lesion, some of which we have almost no data on, some of which we have quite a lot, such as the tetralogy patient. In that patient group, though, you would probably consider an EP study, and we probably would place an ICD in that patient and treat the PVCs either with ablation or medical therapy. So to sort of summarize, how many PVCs are too many? As in most things in life, it depends on who the patient is. Some of the conclusions of this talk, I think, should be that all ACHD patients are not created equal, and there's a lot of heterogeneity amongst this patient group. And in a sense, the talk is an interesting one to talk about, but it's just very broad. And the data that exist are high in some lesions and very minimal in others. Clearly, for patients who have higher risk congenital heart disease for arrhythmia, we need to have a higher degree of concern and a lower threshold for invasive evaluation. And these include things like tetralogy of Fallot-like diseases like tetralogy or double outlet right ventricle, single ventricle, Ebstein's anomaly, cardiomyopathy, and LV outflow tract obstruction. Just to give you an idea of how practice varies, at Boston Children's Hospital, every patient who goes for an Ebstein's repair has an EP study prior, including a V-stim study. And I used to follow a patient who had a defibrillator placed because of an inducible ventricular arrhythmia preoperatively. Patient never had an event prior or at least in the 10 years I followed him after that repair. But because of the high-risk nature of this patient, it was their belief that this was a prudent move. The risk rises with the time from repair. Most things we feel like the longer you go without a problem, the better it is. Actually, in ACHD world, almost every single problem becomes more likely the longer you are from surgery, and arrhythmia is certainly one of the most important examples of that. Older age is higher risk. It's higher risk because of the issue I just mentioned, that the longer you go from the surgery, the more likely you're going to have arrhythmia. But it's also because as you get older, you're at risk for all the other causes of arrhythmia, such as coronary disease. And of course, it is believed that most ACHD patients will be at higher risk for coronary disease because of their generally sedentary life quality. It's interesting to note that when I started my career, it used to be believed that ACHD patients were at lower risk for coronary disease than the general population. But that was really only believed because there were so few adults who had reached an age where they could get coronary disease that, of course, the incidence was, or the prevalence was very, very low in the population. But I think it's pretty clear, it makes very good sense that these patients will be at risk going forward. They're at higher risk for reentrant arrhythmias as they get older, and of course, unpredictable causes. Symptoms are very important. It's an important thing to always keep in mind when an ACHD patient complains of possibility. In my experience, most ACHD patients rather do not complain. So I would take that seriously for palpitations. And most important of all, what I'm discussing with you this morning is likely to change, and this will probably be outdated very soon. It's an evolving topic, and as the Greek philosopher Heraclides once said, things change. So that's basically it. That was the talk that I gave this week at Heart Rhythm. Does anybody have any comments or questions about this topic? Okay, I can see I've left you dumbfounded. So if that's the case, I guess we'll stop right now, and hope everybody has a great day today.
Thank you, Dr. Bass.
Thank you, Dr. Bass.
Bye-bye.